Good afternoon, everyone, and welcome to the Department of Health webinar 2023 Pennsylvania State Nursing Licensing Facility Licensure Regulations, Guidance, and Clarification. My name is Ann Chronister, and I'm the Director of the Bureau of Long-Term Care Programs here at the Department of Health. Thank you all for attending today. The presentation will take approximately an hour and a half, and as a reminder, it is being recorded. Any questions on the presentation today should be emailed to the long-term care resource account or email account that was shared in the meeting invite and will also be included on the last slide today. If time permits, we'll address any questions that have been entered into the chat. At this time, I'd like to introduce the presenter today, Susan Williamson, Director of Nursing Care Facilities with the Department of Health.
Thank you, Anne. Can I do a quick sound check? Can you hear me?
I can hear you.
Thank you. Okay. Again, thanks everyone for joining us. Exciting information to share. The regulations were last updated in 1999, and now we have some additions and changes. They're all updated with residents in mind. To help ensure the quality of life and quality care for the residents and some additional transparency. Um, Again, the regulations are minimal standards. Facilities are encouraged to not only meet the regulations, but to exceed them for the maximum benefit for the residents. Okay. Moving right along, our objectives for today, participants will have general understanding of the updated long-term care licensure regulations. They'll be able to define the areas of changes. They'll be able to define what needs to be documented to demonstrate compliance with various requirements of the new state nursing facility licensure regulations. And also, hopefully, they will be able to understand the intended benefits to residents in incorporating their involvement in appropriate areas of compliance, such as policies on residents' rights and facility assessment. Ooh, getting ahead of myself here. So I've included a timetable of the effective dates. As you're probably already aware, we have some rolling effective dates. Um, so this you can pull out and easily tell what the timetable is for the regulations that are going into effect. A couple already went into effect beginning February 1st, and we'll touch on them in a little bit. So, and a little bit is here. February 1st, 201.12a, notice and opportunity to comment, went into effect this past February 1st. So in addition to requirements in section 201.12, a prospective licensee of a new facility shall concurrently provide written notice to the Office of the State Long-Term Care Ombudsman when the prospective licensee submits its application. And in addition to requirements, in 201.12, a prospective licensee for a change in ownership of a facility shall concurrently provide written notice to the following, and this includes residents, employees, and the long-term care ombudsman at the state level. The written notice then we outline here what is required in the written notice: the name, address of the facility, name, address of the prospective licensee, and the contact information for the state long-term care ombudsman. So that has already gone into effect, not something that you are concerned about on a daily basis, but if there is going to be a change in ownership, there is notice that is required. And you may be required to provide a copy of that notice to the department should you be asked.
Susan, I'm so sorry to interrupt you there. It looks like some folks are having some issues with their sound.
Okay.
So I just want to see, there are some folks who do have sound. So if everyone could make sure that their Teams volume is up all the way, or if they're listening through headphones or their computer that they're able to see it. And we are actively working to admit everyone in the waiting room. So, Susan, I'm so sorry. Let's just hold on just a second here.
That's okay. I'll pause for a moment and hopefully we can get everybody in before they miss too much information. Thank you, Maggie. So we'll continue. I will say that we do intend to post the slides on the website. So if you missed the first couple, you'll be able to catch up with those then. Okay. All right, continuing. So July 1st, 2023, big day. All new requirements with the exception of these listed on the slide will go into effect. And this it does include the first stepped increase in the staffing minimums found at 211.12. So applicability, subparts apply to the long-term care nursing facility as defined in section 802.1 of the Act. In 201.2 requirements, the department incorporates by reference 42 CFR Part 483 Subpart B of the federal requirements for long-term care facilities relating to requirements for long-term care facilities. So you're probably familiar with the incorporation of the federal regulations into the state, as we had some of those incorporated before. So it won't be completely new, but we are incorporating the entire 483 subpart B, with the exception, of course, there's an exception, 42 CFR 483.1 and the requirements under 42 CFR Part 483 subpart B for the transmission of data and minimum data set reporting to the Centers for Medicare and Medicaid Services, unless the facility is participating in the Medicare and Medical Assistance Program. So what that means is licensed only facilities, facilities that do not participate in Medicare and Medicaid are not required to submit the MDSs for reimbursement. CMS has authority to collect MDS data for residents who are on Medicare and or Medicaid certified units. Assessments that are completed for purposes other than OBRA and SNF PPS reasons are not to be submitted to CMS through the KEYS system. So in other words, if they're not on your Medicare or Medicaid, if you are licensed only, you do not need to submit those. There's interpretive guidelines put into the regulations to keep you reminded of that. So section 201.3 is the definition section. I did not put all the definitions into slides, but I do want to encourage you to go look at those definitions, read through them, and note the changes. We'll go over a couple as we go through the other requirements, but please make sure you review the definitions in the regulations. Now, again, part of these regulations go into effect in October, and that mainly has to do with the ownership and management. There's requirements for a new facility, or if there's going to be a change of ownership. And when we get closer to October, we will do some additional training on this so that everyone's aware. Again, this isn't something that affects you on your daily or your licensure survey. This is requirements when there's a new facility coming in or a change of ownership. And much of it has to do with transparency and making sure that we have owners in Pennsylvania that are on the up and up, for lack of a better term. All right. So it would be extremely helpful if the chats could pause until the end. It would be great. It's distracting me and I'm losing my train of thought. So thank you. In addition to the application fee, there's a lot of additional information that will be required come October. Again, we will cover that when we get closer to October and we have the rest of this under our belts. And this slide in the blue, you'll note that this is the portion of this regulation that went into effect in February with the notification requirements with the change of ownership. And again, there's interpretive guidelines that have been incorporated for you to review when the regulations are posted on the website. The requirement to notify residents and employees of the facility can be met through the prospective licensee working with the current licensee to post written notice of the potential change of ownership in a public location at the facility in a conspicuous manner. Direct notice must be given to the Office of the State Long-Term Care Ombudsman. A copy of that letter or email that's sent to the Office of the State Long-Term Care Ombudsman would meet the requirement of notification to that office. And again, if that is occurring at your facility, you may be required to provide that proof should the department request it. Again, evaluation of the application comes into effect in October. 20113, issuance of a license for a new facility or change in ownership. We've added the name and address, or we will be come July, adding the name and address of the owner of the facility to the license. In this section, we eliminated the fee schedule as that's already outlined in the Healthcare Facilities Act, and provisional and regular licenses were split out. So one item to note is that in 20113B C, to return to a regular license, a licensure survey must be completed to determine substantial compliance. This would not be a revisit. That's not a new requirement. That's just we have quite a few questions come in on that for folks who might have gotten a provisional license, and so we just wanted to add some information that says, you have to have not only your revisit, but another licensure survey to determine if you can return to a regular license. Continuing the license section, again, the information in red is effective July 1st, 2023, and the blue on this slide will be October 31st. So when submitting your licensure application come October 31st, you're going to be required to submit a financial report that meets the requirements in 20112B8. Again, we'll cover that in more detail before the October effective date. (20114) responsibility of licensee. Effective July 1st, 2023, we added some items like complying with all laws, rules, regulations, and orders. We've learned several things from the public health emergency and the COVID pandemic. This will assist with issues with things like the Secretary of Health issuing orders for facilities to follow certain directions. We will now have a regulation to back this up. Additionally, the time frame was added for reporting incidents per Chapter 51. Interpretive guidelines that have been added as reporting should be through the department's designated system. And I believe all of you are aware at this current time, it's the ERS system, the event reporting system. Additionally, in 20114, responsibility of licensee, we added that the long-term care ombudsman should be notified of a strike. We added the inspection report requirement here, making it available to interested parties and having on file the most recent. You're familiar with that, I'm sure, from the federal. And here is an important change. We also added that the facility should do the facility-wide assessment at least quarterly, which the federal requires the facility to complete that annually. We are requesting that you do it quarterly. The facility-wide assessment should be shared with the governing body, medical and nursing staff, and other professional and supervisory staff as indicated quarterly. Facilities should already be completing the annual facility assessment per the CMS regulations. This is an opportunity to utilize that same assessment more frequently. And as we know, residents and their staff change pretty frequently. It would behoove facilities to ensure that they do maximize the benefit of this assessment so that it is useful and not a burden for administrative or an administrative lift with no positive outcomes. You'll need to develop a method of documentation to indicate to a surveyor that the assessment is complete and is utilized to make changes that are necessary. So we won't be providing any kind of form for you to utilize. You will need to come up with a plan on how you're going to document that so that the surveyors will have that available to them when they come. 20515 restrictions on license. A license becomes automatically void without notice if any of the following conditions exist. The license term expires unless the term expires due to a departmental delay, a federal emergency, or a state disaster emergency. Again, another lesson learned from COVID in that sometimes we have higher priorities on our list, as many times you do, and this provides us a bit of some coverage here should that occur again. And again, you'll notice that in section C there, it says reserved, and I should have mentioned this earlier, but reserved means basically there's not a regulation there now for you to adhere to. So we skip past that. Okay, restrictions on license. 201.15A is new, again, effective July 1st this year. This adds what licensure enforcement actions a department may take against a facility. So those are typically, you refer back to the Healthcare Facilities Act to learn what they are, but we felt it was pretty important to put them right here so you are well aware of what enforcement could take place should you not be able to comply. 201.15B is also new and it outlines appeal rights. So neither one of these will be surveyed by surveyors. These are directions and information for enforcement and appeals should you receive an enforcement action from the department. 201.17 location. It's been modified to allow other levels of care in a facility provided they meet the 4 requirements listed here. So when surveyors are in your building and there's other levels of care in there, they'll want to make sure that sections 1 through 4 here are met. So for new facilities, the approval of the department consists of a letter from the facility providing the information in paragraph 1 through 4 to the department and a response from the department approving and indicating that the facility meets all 4 criteria. For existing facilities that currently have exceptions, the department will check to see if the facility meets these criteria during its annual licensure survey and will provide an approval letter or remove the exception. If the facility does not meet the criteria, the department will consider whether the facility still requires an exception to the requirements of this section. So the 4 criteria, the provider is licensed as applicable, the provider operates or provides other health-related services such as personal care, home health, or hospice services. The shared services may include services such as laundry, pharmacy, and meal preparations, and the facility shall be operated as a unit distinct from other health-related services. Okay, 20118 management. We incorporated the federal regulations here relating to administration for 42 CFR 48370D. We have in here about protection of personal and property rights of the residents while in the facility and upon discharge or after death, including the return of any personal property remaining at the facility within 30 days after discharge or death. So the facility is responsible to return that property. However you choose to do that through mail or a courier service or whatever is up to you. But if we do understand that there are times when a family may say, I don't want the stuff, just get rid of it or give it to someone else. You really need to have that in writing from the family. However, we also understand that sometimes the families won't come back in and give you that writing. So we will accept documentation of a conversation with the family. So for instance, your social services person may call the family and say, what would you like us to do with the clothing that is here or the television that's left? And they say, donate it to Goodwill or give it to the roommate or something like that. If they have documentation in the record of that conversation, we will accept that. In Section C, the governing body shall report to the department within 30 days changes to the information that was submitted with the facility's application for licensure. So the facility, basically what this means is you need to report to the Department of Health within 30 days any changes submitted. So if there's a change in the management company, you've got a new contractor for management, you've got new county commissioners, your administrator has changed, you've changed the address, some 911 address things have caused changes in physical addresses, things like that, ownership. We all need to be notified within 30 days of those things. So interpretive guidelines are included. The report should be in writing, preferably in the form of a letter to the division via email to a newly established CHOW email address, and that again will be provided for you so you don't have to memorize this. But there is a CHOW, or that's the abbreviation for change of ownership, email address, and those kind of changes would be sent there. Okay, continuation of 20118 management. The governing body shall adopt effective administration resident care policies and bylaws governing the operation of the facility in accordance with legal requirements. The administrative and resident care policies and bylaws shall be in writing, shall be dated, shall be reviewed and revised in writing as often as necessary, but at least annually. So you must at least annually review the policies. And the policies shall be available to the residents, their representatives, and for review by members of the public. So in section D, Point 1, the administrator appointed by the governing body under 42 CFR 48370D2 shall be currently licensed and registered in this Commonwealth and shall be employed full-time in facilities that have more than 25 beds. Okay, so facilities with 25 beds or less may share an administrator, providing that they meet all of these criteria, and there are several criteria. So before the regulation stated that you could share an administrator and you really had to write to us and get an exception for that. Now we're incorporating that in, but there are criteria that must be met. When sharing an administrator in a facility 25 beds or less, the administrator is expected to provide adequate time between the two facilities to ensure quality of care and quality of life for the resident population in each facility. Um, there's interpretive guidelines. The facility will need to provide evidence that the director of nursing has knowledge and experience as noted in number 4. And examples of that evidence would include a resume, performance standards and evaluations, or maybe even a letter from the medical director. We just want to make sure that there's someone guiding the care for the residents at all times. The administrator's anticipated biweekly work schedule has to be publicly posted in the facility. The anticipated work schedule shall be updated within 24 hours of a change. So if the administrator has to change the schedule, he or she has 24 hours to change that schedule posting. So the idea behind this is so that everybody knows if they need to go to someone, who do they go to? This section also added the housekeeping responsibilities of the administrator here. 2.1, sanitary, orderly, comfortable environment through housekeeping and maintenance. Added at least monthly, they have to have ongoing relationship with the governing body, medical and nursing staff, and other professional and supervisory staff through meetings and reports. Interpretive guidance is that meetings and reports must occur at least on a monthly basis, both meetings and reports. If the facility deems more often, certainly you can hold additional meetings. Virtual meetings do count as a monthly meeting, and the minutes or notes from meetings will be accepted as a monthly report. Okay. Sorry, there we go, getting ahead of ourselves again. Okay. Section F really adds the resident representative. Resident representative has been updated from responsible person. So you'll see that throughout, that resident representative is added. In section 8, when the facility accepts the responsibility for the resident's financial affairs, the resident or resident representative shall designate in writing the transfer of the responsibility. The facility shall provide cash if requested within 1 day of the request, or a check if requested within 3 days of the request. If a facility utilizes electronic transfers, the facility shall initiate an electronic transfer of funds if requested within 1 day of the request. So really making um, the resident funds available to them on a timely basis. We now have things like Venmo, PayPal, that money can be transferred quite rapidly. So we felt that these timeframes were acceptable. Okay. Personnel records. Personnel records shall be kept current and available for each facility employee and contain all of the following information: job description, educational background, employment history, performance evaluations, including documentation of any monitoring, performance, or disciplinary action related to the employee, documentation of credentials, which shall include at a minimum current certification, registration, or licensure, if applicable, for the position to which they are assigned. A determination by a healthcare practitioner that the employee, as of their start date, is free from communicable diseases or conditions listed in 27.155. This list has been derived from the previous interpretive guidelines, so it was written right in so you can see it. Records relating to a medical exam if required, so this is a continuation of what's required in the personnel file. If required, the medical exam if required by a facility, or attestation that the employee is able to perform the employee's job duties. documentation of the employee's orientation to the facility and the employee's assigned position prior to or within a week of their start date. Some clarification on that and interpretive guidance. A facility needs to provide documentation that an employee has participated in orientation to the facility and the assigned position either prior to start date or within 1 week. This could be a checklist that indicates the employee has been shown around the facility and knows where key areas are as well as key personnel, and that they have been provided a job description with expectations outlined. Number 7, documentation of the employee's completion of required trainings under this chapter, including documentation of orientation and other trainings. So 201.20 outlines staff development requirements, so you can take a look at that. Number 8, a copy of the final report received from the Pennsylvania State Police and the Federal Bureau of Investigation is applicable in accordance with OPSA and applicable regulations and all adult protective services. Number 9, in the event of a conviction prior to or following employment, documentation that the facility determined the employee's suitability for initial or continued employment in the position to which the employee is assigned. So, suitability for employment shall include a review of the offense, the length of time since the individual's conviction, the length of time since incarceration, if any, evidence of rehabilitation, work history, and the employee's job duties. So you want to look at having a way to document that you've reviewed the conviction and determined that the person is suitable for employment in the position that you've selected them for. And right in the regulation, there are some pointers on what types of items to review. And just as we talked about, 201.20 is staff development, ongoing coordinated educational programs, including at a minimum annual in-service training on the topics outlined in the federal regulations at 4395, in addition to the following: accident prevention. And for this one, personnel training on the topic of accident prevention should include the prevention of accidents to both residents and staff. Restorative nursing is number 2. Emergency preparedness in accordance with the federal regulation. Fire prevention and safety in accordance with the federal regulation. Resident rights, including non-discrimination and cultural competency. Training needs identified through the facility assessment. So anything that you identify when you do the assessment should be included in this training. An employee shall receive appropriate orientation to the facility, its policies, and to the position and duties. The orientation shall include training on the prevention, detection, and reporting of resident abuse and dementia management, as well as communication skills. And of course, you have to maintain written records. Use of outside resources. In addition to the requirements under the federal regulation 48370G, the responsibilities, functions, objectives, and terms of agreements related to outside resources shall be delineated in writing and signed and dated by the parties. Section D is reserved. E, if a facility acquires employees from outside resources, the facility shall obtain confirmation from the outside resource that the employees are free from the communicable diseases and conditions listed in 27.155 and are able to perform their assigned job duties. Section 201.22, Prevention, Control, and Surveillance of Tuberculosis. You'll note that this section became much smaller. As we move through the years, some of the information has changed through the Centers for Disease Control and Prevention, so we needed to make sure that we were up to date with that. So the TB infection control plan includes residents and employees, and the facility must follow the CDC guidelines and utilize an approved method of management, screening, and surveillance. For existing facilities that currently have exceptions, The department will review the existing exception during its annual licensure survey and will remove the exception from prior to July 1st, as it will likely not be necessary after July 1st with this updated guidance. And I know that there may be questions regarding this because it went from very detailed to quite a bit less information. So I would encourage you to submit those questions through the email address that will be provided and has been provided, as it will be important for us to answer those questions so that everybody can see the answers. Moving right along. 201.23, closure of facility. So in addition to the requirements set forth in the federal regulation at 483.70 L and M, the following conditions apply to the closure of a long-term care nursing facility. So the facility shall develop a closure plan that includes the following: the identification of those who will be responsible for the daily operation and management of the facility during the closure process. So we need to know who's in charge. The roles and responsibilities and contact information for the facility owner and the administrator, or any replacement or temporary manager during the closure process. Who's in charge and what are they doing? Number 3, assurance that no new residents will be admitted to the facility after the written notice of closure is provided under subsection C.3. Continuing, a plan for identifying and assessing available facilities to which residents can be transferred, taking into consideration each resident's individual best interest and residents' goals, preferences, and needs regarding services, location, and setting. This shall include interviewing each resident and resident representative, if applicable, to determine each resident's goals, preferences, and needs, and offering the opportunity to each resident and resident representative, if applicable, to obtain information regarding options within the community. So we really want the residents' interests and their goals and preferences to be taken into account when they're going to go through what is a very difficult time moving from their home to a different area. So, um, interviewing them and then taking a look at what may be available in the community. Perhaps they are at a point where they may return home with home care services. I don't know, but that's going to be very important when doing this. Providing residents and representatives with information or access to information regarding providers and services. A closure plan should be developed for the above listed information, understanding that residents change over time. However, when a facility plans to close, the plan should be updated as soon as possible. This means identifying obstacles to transferring residents, such as a lack of current payment source, and resident identification issues, such as a lack of a social security card, driver's license, or identification card. So, all things that may be encountered when this situation arises. A plan for communication and transfer, so additional information needed on this closure plan. Provisions for the ongoing operations and management of the facility, its residents and staff during the closure process that include the following: payment of salaries and expenses, continuation of appropriate staffing and resources to meet the needs of the residents, including provisions of medications, services, supplies, and treatment. One of those services including dietary services. Ongoing accounting, maintenance, and reporting of resident personal funds. Labeling, safekeeping, and appropriate transfer of each resident's personal belongings. And so basically, the plan needs to include assurances that you're not going to admit any additional folks, and you're going to have a plan for continuation and funds to continue operations until you can safely transfer those residents elsewhere. The facility shall provide the notice of closure and the closure plan developed under subsection C1 to the department for approval at least 75 days prior to the proposed date of closure. So 75 days prior to when you decide that you're closing, you need to send that plan to us for approval. Additionally, at least 60 days before the proposed date of closure, the facility shall provide written notice of the proposed closure to the following: residents and their representatives in writing or in a language and manner they can understand, employees, the state long-term care ombudsman, and Department of Human Services. And the written notice provided under subsections C.2 and C.3 shall contain the following information: the date of the proposed closure, contact information for the facility representative delegated to respond to questions, contact information for the state long-term care ombudsman, and a transfer and relocation plan of residence. Additional information for closure. Basically, D through F have remained the same from before. G, the licensee of a facility shall file proof of financial responsibility with the department to ensure that the facility continues to operate in a satisfactory manner until closure of the facility. Okay. On the other hand, 20124 talks about the admission policy. We've added resident representative again, but there's no real significant changes between A, B, C, and D. However, E, the facility must have a policy and procedure for admissions process for residents to include the introduction of residents to at least one nursing staff for the unit and to direct care staff assigned to them. Staff need to review orders for immediate care, and this should assist the resident in establishing a relationship immediately and know who can help them. So, I don't know about you, but the first thing what I do when I enter a new place is locate the restroom, just in case I need to use that, and then find whoever's in charge. So I think this just makes sense that we need to make sure that the residents aren't just brought in, lifted off the litter into a bed in a very strange place. Um, so this is trying to assist with that. Orientation of the resident to the facility and location of essential services and key personnel, including dining room, nurses' workstations, and offices for the facility's social worker and grievance or complaint officer. A description of facility routines. Usually, one of the next things after where's the restroom is when's supper. So a description of facility routines, including nursing shifts, meal times, and posting of menus, discussion and documentation of the residents' customary routines and preferences to be included in their care plan developed under the federal regulation, assistance to the resident in creating a home-like environment and settling and securing personal possessions in the room to which the resident has been assigned. So the coordination of introductions, orientation, and discussions under this subsection E shall be the responsibility of the facility's social worker or a delegee designated by the governing body. So the activities included under subsection E1 and 2 shall occur within 2 hours of the resident's admission. The activities in subsection E3 and 4 shall occur within 24 hours of a resident's admission, and the activities included under subsection E5 shall occur within 72 hours of admission. So orientation to the facility, location, essential services, key personnel, dining room, nursing workstations, offices for social worker and grievance, 2 hours. Facility routines, nursing shifts, meal times, posting menus, customary routine, discussion and documentation, 24 hours. You got a day to do that. And assistance in creating a home-like environment and settling and securing their personal items, 72 hours. For information regarding how to create a home-like environment, the federal regulation at 48310 discusses information on home-like environment. Resident representative. This section was formerly known as power of attorney. It's been changed to bring it up to current terminology, and it addresses the situation where a resident's family member works in the facility, and also that the facility may be a representative payee as permitted through the Social Security Act. 201.27 has not changed. It's the advertisement of special services, and 201.28 is reserved. So we'll move into 201.29, or resident rights. The governing body of the facility shall establish written policies regarding the rights and responsibilities of residents as provided in the Federal Regulation 48310 and this section. Through the administrator, the governing body shall be responsible for development of and adherence to procedures implementing the policies. The written policies shall include a mechanism for the inclusion of residents or a resident representative in the development, implementation, and review of the policies and procedures regarding the rights and responsibilities of residents. So there's modifications to this section A as it relates to the resident rights, and the big changes including residents, their representatives, and the development and implementation. It's the expectation that residents would be involved in their life and care. This is their home, and they need to be aware and involved if they choose with how they're cared for. So facilities will need to come up with a plan on how they intend to ensure this regulation is carried out. Resident council could be a way, or you may also include the residents in deciding how best to include them in this. The facility shall post in a conspicuous place near the entrances and on each floor of the facility a notice which sets forth the list of resident rights. The posting of resident rights shall include the rights under subsection C3 and 48310, which is the federal regulation. A facility shall provide personal notice of the residents' rights in accordance with the federal regulation 48310 G16. A certificate of the provision of personal notice shall be entered in the resident's medical record. So the facility has to post the resident rights near the entrances and on each floor as a federal regulation, and they must provide personal notice. So you're going to have some sort of record to keep in the resident's medical record showing that you provided notice of resident rights personally to that resident. And Exhibit A is a resident rights template, and that has been posted on our website. So you can feel free to go to that section of the updated regulations, and you'll see Exhibit A for your use. Section C.3, in addition to the residents' rights at 48310, they have the rights to the following. If changes in charges occur during the resident's stay, the resident or the representative shall be advised verbally and in writing reasonably in advance of the change. Reasonably in advance shall be interpreted to be 30 days prior to the change unless circumstances dictate otherwise. If a facility requires a security deposit, the written procedure or contract that is given to the resident or resident rep shall indicate how the deposit will be used and the terms for the return of the deposit. Remember, a security deposit is not permitted for residents receiving medical assistance. And number 2, prior to transfer, the facility shall inform the resident as to whether the facility where the resident is being transferred is certified to participate in Medicare or medical assistance programs. So if the resident is receiving Medicare and or medical assistance and you're transferring them, they need to know whether or not that facility accepts their form of payment. Another portion of the resident rights is experimental research. Any experimental research has to go through the Department of Health IRB. So many folks will submit a research project that has gone through another institutional review board, you need to know that it must go through the department's institutional review board. So please review this section if you intend to participate in experimental research or treatment. Also, non-discrimination information was added here in number 4. A resident has the right to care without discrimination based upon race, color, familial status, religious creed, ancestry, age, sex, gender, sexual orientation, gender identity or expression, national origin, ability to pay, handicap or disability, use of guide or support animals because of blindness, deafness, or physical handicap of the resident, or because the resident is a handler or trainer of support or guide animals. Okay. 201.30 is reserved. 201.31 remains the same. 201.32, 0.33, 0.34, 0.35, 0.36, 0.37, and 0.38 are all reserved, as is Chapter 203. So we will move on to Chapter 204. Okay, Chapter 204, Physical Environment and Equipment Standards for Construction, Alteration, or Renovation of Long-Term Care Nursing Facility. So this chapter applies to alterations or renovations approved on or after July 1st, 2023. And facilities must adhere to the FGI Guidelines 2018 edition. So this is anything approved on or after July 1st, 2023. Okay. So I'm going to buzz through these quickly. You can read these on your own. They're very similar to Chapter 205, except the 2018 edition of the FGI Guidelines. Building plans, buildings and grounds, basement, existing facilities that use the basement for things like physical therapy or central supply would need to be granted an exception by the department. Keep that in mind. Resident rooms. This talks about a bed for a resident may be placed only in a room approved by the department as a resident room. Just a reminder, bed may also mean recliner. So it's whatever device the resident chooses to sleep on. Also here, an F, a resident shall be provided with a drawer or cabinet in the resident's room that can be locked. Just a reminder, they'll need a key for that. Locks, laundry, utility rooms, bathing facilities, toilet facilities. These should look pretty familiar. Equipment for bathrooms. Toilet room equipment, linen, and supplies. Windows, dining, lounge, and recreation. Just want to touch base on the windows. Each window opening in the exterior walls that are used for ventilation shall be effectively covered by screening. And a room with windows opening it onto light or air shafts or onto an exposure where the distance between the building or an obstruction higher than the windowsill is less than 20 feet may not be used for resident rooms. I just want to remind you when looking at windows, take a look to see if they are safe for the residents that are in that room. Experience tells me we've had a lot of residents that use the windows as an elopement mechanism. So just a reminder. Storage, plumbing, heating, ventilation, air conditioning, and electrical, airborne infection isolation room. And here we are at Chapter 205. So the existing chapter applies to facilities and areas of facilities not doing new construction, renovations, or alterations. The July 1 date does not mean that an occupancy on July 1 means the work is required to comply with the FGI guidelines. It is important to remember that the date is for plans approved July 1 or after. Plans approved June 30 will be under the old requirements and have the life of the project to complete under the old requirements. This information can be found on the letter and front page of the plans when you submit your plans and the plan review sends you a letter back. It will tell you what codes were used to approve the plans. So if a facility gets plans approved July 1 for renovations on one wing, only that wing will need to meet compliance with the FGI, and the remainder of the building will be under the existing requirements until such time they are renovated. Chapter 207 is reserved. In Chapter 209, under smoking, there's an addition. Policies regarding smoking shall be adopted. The policies shall include provisions for the protection of the rights of smoking and non-smoking residents. The smoking policy shall be posted in a conspicuous place and in a legible format so that they may be easily read by residents, visitors, and staff. Reportable diseases. We added bed bug infestations to the reportables, and that will be added to the event reporting system, so that's able to be chosen. Medical director. Here's another significant change. So in addition to the requirements of the federal regulation at 483.70H, the medical director of a facility shall be licensed as a physician in this Commonwealth and shall complete at least 4 hours annually of continuing medical education, or CME, pertinent to the field of medical direction or post-acute and long-term care medicine. So the medical director is going to need to provide proof to you of at least 4 hours of CMEs. Acceptable proof would be copies of the CME certificate or a registration or attendance confirmation form. Additionally, we're listing out the medical director's responsibilities, number 3 through 10. Ensuring the appropriateness and quality of medical care and medically related care, assisting in the development of educational programs for facility staff and other professionals, working with the facility's clinical team to provide surveillance and develop policies to prevent the potential infection of residents in accordance with the infection control requirements at 483.80. Cooperating with facility staff to establish policies for assuring that the rights of individuals are respected, supporting and promoting person-directed care, such as the formation of advanced directives, end-of-life care, and provisions that enhance resident decision-making, including choice regarding medical care options. Identifying performance expectations and facilitating feedback to physicians and other healthcare practitioners regarding their performance and practices. Discussing and intervening as appropriate with a healthcare practitioner regarding medical care that is inconsistent with current standards, and assisting in developing systems to monitor the performance of healthcare practitioners, including mechanisms for communicating and resolving issues related to medical care, ensuring that other licensed practitioners who may perform physician delegated tasks act within their scope of practice. Verbal and telephone orders. So oral was changed to verbal. Verbal orders for care and treatment need to be signed by the physician or the delegee within 72 hours. Orders for medications need to be signed within 48 hours. So care and treatment, 72 hours. Medications, 48 hours. We've had some history over, the last 20 years or more with medication errors. And so we believe that signing their order that they gave you within 48 hours is a reasonable time to catch if it was not what the practitioner ordered or transcribed incorrectly or things like that. Verbal orders for care, treatment, and medication shall be accepted only under circumstances where it is impractical for the orders to be given written by the physician or delegate. A few changes here, just changing the word oral from verbal, and we've added that you can use other secure electronic transmission. So while fax may still be used, it's probably being mostly faxed out or phased out. But we do have some new technology in secure electronic transmission, which would be appropriate to use. Procedures in the event of death. So all personnel need to be have the postmortem procedures available to them. And the documentation shall be in the resident's clinical record that the next of kin, guardian, or resident representative has been notified of the resident's death. The name of the notified party shall be written on the resident's clinical record. Medical records. This really notes that the medical records are confidential and require written consent to release. However, I will draw to your attention that it is not necessary for authorized representatives of the state and federal government during the conduct of their official duties, and not necessary for the release of medical records for treatment purposes in accordance with federal and state law. Additional information, medical records. You must inform the department within 30 days of providing notice of closure, a plan for the storage and retrieval of medical records. We include the federal reference in here, items required under 48370I5, and a list of, at a minimum, what must be included. More information on medical records. The word medical was adjusted there, otherwise the same. Dietary services, 211.6. Menus shall be planned and posted in the facility or distributed to residents at least 2 weeks in advance. Records of menus of foods actually served shall be retained for 30 days. When changes in the menu are necessary, substitution shall provide equal nutritive value. And a reminder that dietary personnel, this is not different from before, shall practice hygienic food handling techniques, wear clean outer garments, maintain a high degree of personal cleanliness, and conform to hygienic practices while on duty. Always make sure to wash their hands thoroughly with soap and water before starting work, after visiting the toilet room, and as often as necessary to remove soil and contamination. 211.7, physician assistants and certified registered nurse practitioners. Wanted to point out A is reserved and 1 is reserved, as is C, D, and E. But B, if a facility utilizes services of a physician assistant or CRNP, the following apply. There has to be a list posted at each workstation of the names of the supervising physicians and the persons and titles whom they supervise. Not different. Copy of the supervising physician's registration from the State Board of Medicine or Osteopathic Medicine, and the physician's assistant or certified registered nurse practitioner certificate shall be available in the facility. And a notice plainly visible to residents shall be posted in prominent places in the institution explaining the meaning of the terms physician assistant and certified registered nurse practitioner. They need to be aware of who their practitioner is. Basically, that's what that says. Okay, use of restraints. So if a restraint is used, a facility shall use the least restrictive method for the least amount of time to safely and adequately respond to individual resident needs in accordance with the resident's comprehensive assessment and comprehensive care plan. The following shall apply. When recurring restraint is ordered, the facility shall document the need for the restraint and the personnel responsible for performing the intervention on each shift. A facility shall document the type of restraint and each time a restraint is used or removed. And determining the least restrictive method for the least amount of time, the following minimums apply. Physical restraint shall be removed at least 10 minutes out of every 2 hours during normal waking hours to allow the resident an opportunity to move and exercise. During normal waking hours, the resident's position shall be changed at least every 2 hours. So, least restrictive, released at least 10 minutes every 2 hours, and position changed when awake. Pharmacy services. So we have in section B, 211.9B, facility policies shall ensure that medications are administered by authorized persons as indicated in 201.3. That's where the definitions are. And D has some change about medications, both prescription and non-prescription, shall be administered under the orders of the attending physician or their delegee. Again, resident representative added to this. And some changes at the end of pharmacy, including written policies and procedures for the disposition of medications that address all of the following. So many of these involve making sure that the disposition of the medications is proper and having a plan, documentation of actual disposition of the medications, including the name of the individual disposing of them, and again, a method of disposition to prevent diversion or accidental exposure consistent with applicable federal and state requirements, local ordinance, and standards of practice. And again, these sections are speaking about the emergency medication kits. Important that it's readily available to staff, making sure that the have policies and procedures pertaining to the use, content, storage, security, refill of, and inventory tracking for the kits. The quantity and categories of medications and equipment in the kits shall be based on the immediate needs of the facility, and criteria for the contents of the emergency medication kit shall be reviewed not less than annually. Resident care policies added nursing and mental and psychosocial needs of residents. 211.11 was reserved. 211.12, the moment you've all been waiting for, the discussion on the nursing services changes. So 211.12A is now reserved. B, full-time director of nursing that's qualified. The director of nursing shall have in writing administrative authority, responsibility, and accountability for the functions and activities of the nursing services personnel and serve only one facility in this capacity. And then it goes into the directors responsible for standards of accepted nursing practice, nursing policy and procedure manuals, methods for coordination of nursing services with other resident services, recommendations for the number and levels of nursing services to be employed, general supervision, guidance, assistance for residents in implementing the resident's personal health program. Moving right along. Section 211.12. E, the facility shall designate a charge nurse who is responsible for overseeing total activities within the facility on each tour of duty each day of week. Taking you back now to section 201.3, the definition of charge nurse. A person designated by the facility who is experienced in nursing service, administration, and supervision, and in areas such as rehabilitative or geriatric nursing, or who acquires the preparation through formal staff development programs, and who is licensed by the Commonwealth as one of the following: an RN licensed by another state as an RN who has applied for endorsement from the State Board of Nursing and has received written notice that the application has been received by the State Board of Nursing. This subparagraph applies for 1 year or until the Commonwealth licensure is completed, whichever period is shorter.
Susan, I think you may have came off mute there a second.
Oh, I'm sorry.
Nope, that's okay.
I might have bumped the thing. So a charge nurse can be an RN or an RN who's applied for reciprocity from another state, and that gives them a time limit of a year or when it's completed, or an LPN designated by the facility as a charge nurse on the night tour of duty in a facility with census of 59 or less in accordance with 211.12. So just want you to review that definition. All right, so then we go into, in addition to the Director of Nursing Services, a facility shall provide all of the following. All of the following. So number one is nursing services personnel on each resident floor. So there shouldn't be a floor in the facility that doesn't have a licensed nurse or a nurse aide or some nursing personnel on the floor. Number two, effective July 1st, 2023, this year, a minimum of 1 nurse aide per 12 residents during the day, 1 nurse aide per 12 residents during the evening, and 1 nurse aide per 20 residents overnight. Effective July this year, a minimum of 1 LPN per 25 residents during the day, 1 LPN per 30 residents during the evening, and 1 LPN per 40 residents overnight. And July 1st of this year, a minimum of 1 RN per 250 residents during all shifts. And since we're running low on time, you can read what goes into effect July 1st, 2024, but we're going to talk about the ratios now, because once we get the ratio thing down, we can probably easily move to the ratios in 2024. So for July 1, 2023, 1 nurse aide, 12 residents day shift, 1 LPN, 25 residents. 1 nurse aide, 12 residents evening, 1 LPN, 30 residents. 1 nurse aide, 20 residents night shift, 1 LPN, 40, and 1 RN per 250 during all shifts, except a facility with a census of 59 or under may substitute an LPN for an RN on the overnight shift only if an RN is on call and located within 30-minute drive of the facility. So that's census of 59 or under, and an RN is within a half an hour on call. Okay, so many questions came up with this. 12-hour shifts. So I know a lot of facilities are running 12-hour shifts, but the ratios have been divided up into 8-hour shifts. So you will need to calculate accordingly. So if you have a nurse aide working from 7A to 7P, you'll calculate that nurse aide from 7A to 3P for the day shift and 3P to 7P for the evening shift. Then the nurse aide that's working 7P to 7A will be calculated using 7P to 11P for the evening shift. Okay. Scenarios. Let's look at some scenarios. So for a 50-bed facility on night shift, there's 3 possible configurations. So in addition to the nurse aides, so we already have the nurse aides figured out. This is for the licensed nurse, because you may substitute an LPN or RN for a nurse aide, but you may not substitute a nurse aide for an LPN or RN. So, and you may substitute an RN for an LPN, but you may not substitute an LPN for an RN except in the facility with census of 59 or under, and a RN on call and 30-minute drive. So 50-bed facility for night shift, you could have one RN and two LPNs, or you could have three LPNs on site and one RN on call in 30 minutes, or you could have two RNs and one LPN. Now, if you're substituting an RN for an LPN, you still would have to have the additional RN to meet the 1 to 250 residents. So it couldn't count for both. The regulation does not indicate by floor unit or etc. So the ratios would be for the facility. Now you want to be cognizant of resident needs, and having staff run for 2 residents upstairs and 3 floors down, they're going to run for the rest of their 12. So you need to apply some thought to that. If a facility is meeting the ratios and has an admission that would require an additional LPN or additional nurse aide, the facility has to meet the provision. There's no leeway, there's no provisions in this to say, well, you can admit it, but you don't have to have the additional staff for 24 hours. There's nothing like that. So if you're going to admit a resident on evening shift and you just meet the ratios, then you're going to have to add additional staff so that when you bring that resident in, that you will meet the ratios still. Okay. So now we're moving into PPD. So a minimum number of general nursing care hours shall be provided for each 24-hour period as follows. So effective this July 1st, the total number of hours of general nursing care provided in each 24-hour period shall, when totaled for the entire facility, be a minimum of 2.87 hours of direct resident care for each resident. So right now, our number is 2.7, so it will be 2.87 come July 1st, 2023. And then July 1st, 2024, it bumps up to 3.2. So only direct resident care provided by nursing service personnel may be counted towards the total number of hours of general nursing care provided under this subsection I. So we have added in the interpretive guidance examples of folks who can be counted and who should not be counted. You should not count orientees, light duty nursing staff, RNACs, hospice, private caregivers, feeding assistants, student nurses, unit clerks, even if they are nurse aides. You can count light duty nursing staff if they are providing direct care, such as nail care or feeding or one-to-one. And this is different from your PBJ. I know it probably feels like we try to be confusing, but lunch times can be counted if the person is on duty, which on duty is physically present and able to personally provide nursing care when needed. So that's a little bit different from the PBJ, I understand. So just want you to know that. And also, staff that accompany residents on appointments should be counted. So if you have a nurse aide taking a resident out to a medical appointment at a specialist, they should be counted. They're providing care to that resident. Managers who don't normally perform direct care but are needed because of call-offs should keep a record of tasks performed for that given day and the amount of time in order to show proof when trying to meet your minimum staffing of 2.87. So we know a lot of that happened during the pandemic, where managers had to pinch hit. We had, directors of nursing or unit managers passing medications and doing treatments and providing care and bathing and probably way more than that. So those you need to keep track of what they're doing that's direct care and count them towards your PPD. That's a big section. 211.15 dental services. So we're incorporating the federal regulation here. Make sure to assure that resident dentures are retained by the resident and they're marked for each resident with an identify for them. 211.16 social services. Change here. You need to note a facility shall employ a qualified social worker on a full-time basis, except a facility with 26 to 59 beds may employ a part-time qualified social worker if the facility assessment indicates that a full-time qualified social worker is not needed. Again, going back to that facility assessment to see the needs of the residents. A facility with 25 beds or less may either employ a part-time qualified social worker or share the services of a qualified social worker with another facility. So reread over that, splits it out a little bit. I do want to point out that there is Act 68 from 2008, which prohibited individuals from using the title social worker without meeting the definition in Act 68, which conflicted with our federal definition of qualified social worker. So there'll be interpretive guidance in the regulation to indicate that the qualified social worker for Pennsylvania would be a qualified social services coordinator. That again, I would point you back to the definitions is where the that interpretive guideline is going to be the definitions for qualified social worker. Okay. Pet therapy. A couple of changes here. Important things to remember. You need to have policies and procedures to ensure all of the following 1 through 7, well, -5, but add 5.1. Careful selection of the type of animal so that they're not harmful or annoying to the residents. Number and types of pets restricted according to the layout of the building. Animals are carefully selected to meet the needs of the residents involved in pet therapy. Animals are up to date on vaccinations and good health and do not pose a risk to the health and safety of residents. Animals are and places where they reside or visit are kept clean and sanitary, and infection prevention and control measures such as hand hygiene are followed by residents and personnel when handling animals. Sections 211, 18, 19, 20, 21, and 22 are reserved. And that brings us to the end of our presentation. And we have about 2 minutes, 1 minute. Let me pull up the chat thing and see if there's any I can answer. We do intend to post again the recording on our website and the slides as soon as we can. We are also working to do a frequently asked question document, which is why it's very important to use this RA email address so we have them all at one place and it doesn't take us too long to pull them together and answer them. And I believe, and Maggie may be able to correct me if I'm wrong, we can take these chat questions to out of here and take them back to be answered. And for some reason,
Yep.
here we go.
Yep. We'll make sure to grab your questions here, and the group will follow up with you. And we'll also be sharing the slides along with the recording, once that's ready available.
Okay. We are at time, so unfortunately, I'm not going to be able to answer any of the questions today, but I assure you, we will get answers to your questions and share them with everyone. So again, I appreciate that you took the time to be on this call, and I hope to be in touch soon.
Thanks, everybody. Have a good day.